Welcome everybody. It's another beautiful Friday afternoon here in Michigan. That means it's time for our latest installment of COPD Navigator Live, our weekly look into the world of chronic obstructive pulmonary disease and how to maximize your best life while living with those symptoms and such. My name is Mike Hess, and today we've got kind of a mixed bag topic of things to talk about. A couple of things that have popped up in the group and led to some great, started off with some good conversations, and we're going to talk a little bit more. It's going to be a little bit of a free-form session today. I did not plan ahead for today, as a matter of fact. We've got a lot of stuff coming up between next week it being Respiratory Care Week and November being COPD Awareness Month. We have a lot of stuff going on, and this particular week just happened to get overlooked, I'm sad to say. But we did have some things pop up that I do want to talk about today, and we'll get to that in a few minutes. Good morning or good afternoon to everybody joining us today, particularly Valerie saying hi. We will start, as we often do, by looking at some of the latest news coming out of the COPD world, and this one actually came out about a month ago. But this was a new study that came out in the Journal of General Internal Medicine, which is not one that we see a lot, but I did look at a lot of the bylines on here, and these are some of the heavy hitters of the COPD world. A lot of good research coming out of this particular group. And this journal article was interesting. It was looking at the use of electronic cigarettes to help people quit smoking. Of course, that's a big controversial topic right now in the world of respiratory disease, and we're always looking for new ways to get people to quit smoking, and it has been frequently thought that the use of electronic cigarettes or vapes or e-cigs, whatever you want to call them, might be one of our greatest hopes in trying to get people off of traditional tobacco cigarettes. Unfortunately, after looking at two of the cohorts for two of the largest COPD studies that have been done so far, one called Spiromics and one called COPD Gene, this study actually found that electronic cigarettes are not particularly useful for helping people quit smoking. They were not associated with any improvement in the cessation of traditional tobacco use, and as a matter of fact, it was found that people who used electronic cigarettes were actually less likely to quit traditional tobacco products than those who had never tried e-cigs at all. In addition, they were found to be a little bit more dependent on nicotine. Looking at those people who were using electronic cigarettes, they had a higher need to use the higher doses of nicotine. And as is probably not terribly a surprise, they were also associated the use of electronic cigarettes was associated much similarly to those with traditional tobacco cigarettes in terms of lung function and respiratory outcomes down the line. Again, this was looking at two of the largest prepackaged groups, I guess you'd say, in the COPD world, existing base of research that was out there. And this was looked at over the course of about 3 years. This was what they call a longitudinal study that they looked at to see what the outcomes were like down the road. Now, of course, this was not what we consider the gold standard type of study, the randomized controlled trial, and the authors are quick to point that out. However, this was an observational study. This is also right up there as far as data quality goes, and unfortunately, we can probably consider these results fairly definitive as far as this cohort goes. That remains to be seen whether people who do not yet have lung disease may benefit from the use of electronic cigarettes, and it is still possible that there are certain groups of people that may use it as a benefit, but personally, I look at it as kind of a treatment of last resort. If we've tried counseling and nicotine replacement and all the other things that we have out there, it's possible that tobacco cessation might be effective with electronic cigarettes, but the data right now is not looking very promising. Hey, Kathy, I'm glad you were able to join us today. Good. I'm glad we were able to time it for your lunch break for a change. Kathy joining us from Tennessee, a long-time supporter of Navigator, and unfortunately we've tried to find some different times that work for a lot of people, and sometimes they don't always work for everybody, and I'm glad Kathy is able to join us today. One other news article out there, this is kind of the flip side of a thing that we've talked about before. We've talked before about trying to find the diamonds in the rough when it comes to news articles and journal studies and things like that that come out. We just had an example of a very good study that came out. Now maybe one that isn't so good, or at least one of those things where the headlines aren't always indicative of what the study actually has to say. Recently, I have a Google alert set up for COPD news to try and keep abreast of some of this stuff. And last couple of days, it kept coming up with these news clips about grapes are associated with improvements in COPD. And I thought, well, that seems a little bit strange. So I looked into it a little bit, and sure enough, that's what all the headlines keep saying. Compound in grapes linked with potential healing of COPD or potential improvements, so on and so forth. But when you dig a little deeper, the story is much less clear. We've known for quite a while that there are certain compounds in things like red wine called resveratrol, that is linked with anti-inflammatory effects, and so it was thought that compounds such as this might be of good benefit to a lot of people who maybe are intolerant of steroids or don't want to use steroids, or are subject to that little bit higher risk of pneumonia when we use steroids. We haven't quite found that kind of benefit with that compound, but some researchers were looking along the lines of grapes, and they found another compound called, hopefully I won't mutilate this pronunciation too much, isorapentinogen, I believe is how you pronounce it. And this compound was also found to have some anti-inflammatory effects in general in the lab setting. And it may someday be of benefit to us when we're trying to talk about inflammatory disease, or specifically with COPD. But we're not there yet. And so unfortunately we see a lot of these headlines come up that, we found this compound and it's got anti-inflammatories, and so it must be good for people with lung disease or other inflammatory problems. And unfortunately that's just not the case. This is another one of those situations where we're kind of jumping the gun a little bit in the media. And I don't want to be one of those quote-unquote mainstream media guys or anything like that, but unfortunately we see that a lot with a lot of science and medicine, that in the quest to deliver good news or to be first or what have you, sometimes we're not always seeing the full picture. We saw that, I believe, earlier or at the end of 2016 when we had some big studies coming out about oxygen, and we're seeing that now with a lot of these compounds that come out. I've seen it with carrots. Because there are certain forms of vitamin A that may have some anti-inflammatory capability, and so everybody starts talking about, vitamin A must be great and carrots are great and so on and so forth, and unfortunately we don't quite get there. So that wraps up our news portion of the day, and we're going to get into some of our scheduled topic, which are our impromptu topic, I guess I should say, which was a question that came up in the group, and this does come up every now and then. One of our group members in COPD Navigator, which is our Facebook group at facebook.com/groups/COPD Navigator, asked, is it normal to not have very much mucus when you're talking about COPD, or when you have COPD, when you've been diagnosed with COPD? And it got me to thinking. Of course, we answered that question, and there are many cases where you don't have a lot of mucus. There are many cases that you do have a lot of mucus. And it got me to thinking, though, about how we look at the concept of normal, especially when we're talking about chronic disease, and especially specifically COPD. And unfortunately, we see that COPD is one of these diseases where normal has a quote-unquote normal has a very broad definition. It's often been said that COPD is a disease that is kind of united by certain symptoms and by airflow obstruction, but it's not even necessarily caused by the same thing all the time. We certainly don't have a lot of the same symptoms in a lot of cases. And it's kind of, it's this umbrella term we use, and it's united only by the symptom of airflow obstruction. There are a lot of different causes, a lot of different treatments. And a lot of people experience their COPD in many different ways. Some people have a lot of mucus and phlegm, and they're coughing all the time, and they're bringing up a lot of stuff, and it's different colors. Some people cough a lot, but it's a very dry cough because they have irritation in their airways. Some people don't cough at all. Some people get very short of breath with very moderate or very low levels of activity. Other people, it takes a lot more to get them short of breath. Sometimes people don't really experience much breathlessness because then they start giving up their activity because they feel that they're not tolerating their activity very well. And so we see a lot of these things, and so it's important to remember that normal is very subjective and very individually defined. Now, of course, you are likely to make certain accommodations for your lung function in your life, and that kind of becomes your new normal, so to speak. And, some people, when you require supplemental oxygen, you have to carry oxygen tanks around with you. And I see Sam Hall joining us lately. I like to highlight him for a moment, and created a very unique safety strap for carrying around oxygen to kind of cut down on fall hazards. But that is, again, one of those things you have to be mindful of when you are experiencing your new normal in the COPD world. These are things that you have to make accommodations for. And it's not always easy. It's not always easy from a psychological standpoint. It's not always easy to get your family and caregivers on board with what is this new normal, especially since it's different for everyone. We have a little over 2,000 people in our Facebook group, and that means we have a little over 2,000 different experiences. We can have people who share similar aspects of that, and we did have a question earlier today about how do you manage when you lose some of that activity tolerance, and when you do have to stay in the house a little bit more. What are things that you like to do to take advantage of those times where you can get out and about? The biggest thing here is to be mindful that there will be change, and that it's important not to just look at the situation as trying to get back to normal, but trying to adapt to your personal new normal, which is going to be different for everybody, and it's going to change as you go through the course of the disease. Not everybody needs oxygen right away, of course, but so there will be some adaptations where we're talking about maybe you're doing pursed lip breathing a little bit more, and you're getting short of breath, which I was trying to spit out there. And that may not, and so you do that as you're exercising, and then maybe 10 years go by, and then you start needing oxygen, and then you need to start making accommodations for that sort of thing. It's important to not get too caught up in the idea that you're not normal, though. And that kind of takes us into part two of the topic that I'm getting into here, or our discussions today, not being alone. A lot of times people start looking at having a chronic disease as this thing where they're never going to be themselves again. They've lost their old normal, they've lost their old identity, and all they are now is this person who is short of breath all the time and coughs a lot and has to take their nebulizer around or their inhalers around. They're always dependent on stuff, and they're hauling all this stuff around, and they're not able to get out anymore. And unfortunately, we start to see that leads to a certain degree of social isolation, what we call it. Most people kind of know it as feeling lonely. When you start feeling short of breath all the time, you are less likely to want to go do stuff. Nobody really enjoys being short of breath, and especially when it happens a lot, it can kind of make you feel different. It can make you feel like an other. Certainly not feeling like your traditional self or your historical self. And so we get into these feelings of, well, I don't want to feel like that, so I'm going to just kind of hang out in my house, and I'm not going to go to that birthday, or I'm not going to go to that celebration, or so on and so forth. And so we see that these feelings of not being able to cope with the new normal lead to these feelings of isolation. And there was a study back in 2013 that was published in the Proceedings of the National Academy of Sciences that really linked the concepts of social isolation and loneliness to increased mortality rates. At our cores, humans tend to be fairly social animals. We like to be around people. We like to have people around us for the most part. I mean, of course, every now and then you get your grumpy old Obi-Wan Kenobi hermit who wants to be by themselves all the time. But by and large, people like to be with their friends and family. And so this group looked at what happens when you start having increased social isolation and loneliness. And they actually separated out the two concepts, figuring that social isolation is kind of the physical manifestation of it, where you are actually not doing a lot of stuff, where you're by yourself for the most part, hanging out in your home, being alone. And loneliness is the psychological manifestation of that. The feelings of being lonely, the feelings of being alone, the feelings of being isolated. And they took those two concepts and separated them out and looked at how they interacted with each other. And a lot of the theory was that these are kind of the same thing, maybe different words for it or different terminology, that sort of thing. But they actually found that they are a little bit distinct in terms of concepts. And that's where we started teasing out the difference between physical social isolation and feelings of psychological loneliness, because they found that when people were actually socially isolated and being alone and not doing much of their stuff, over time they had higher degrees of mortality and poor outcomes. Their quality of health got lower, or their quality of life got lower, their subjective health got worse. That wasn't as much the case with the psychological loneliness. Especially over time, there was a certain time frame, as I recall, if I recall correctly, there was a certain time frame where those two were actually linked. But over time, if they were able to get out of the feelings of loneliness, and they were still feeling isolated, then they still had those negative outcomes. And so that's what I'm saying. It's very important to gain acceptance of the new normal, to understand that you are still you. You are still entitled to enjoy your life, and you are still entitled to be around other people. And it's kind of up to others to start adapting to what is your new normal. I see a couple of comments here, and this is definitely how depression sets in for a lot of people. And Kathy brings us a good quote that I can't help but read in Morgan Freeman voice: "Get busy living or get busy dying." From the movie Shawshank Redemption, and I believe that was likely in the Stephen King novel also. It's been a while since I've read that one. The movie obviously is a little bit fresher in my mind, but that is very true when we start talking about something with chronic disease in general, and especially something that can be limiting of activity, like with COPD. I talk about this a lot with the patients I see here in the clinic. It seems maybe a little bit backwards that we want people to exercise, for example. And if people look at me like, well, if I'm getting short of breath just going to the bathroom or trying to check my mail, how am I going to get on a treadmill? It doesn't make any sense. But we see that it's that same concept of trying to push your limits and trying to continue on with living your life, because we don't want you to get busy dying. This is a chronic disease, and this is absolutely limiting, but this doesn't have to be the only thing that you are. You are still a person. You are still a mother, father, son, daughter, aunt, uncle, grandparent. Whatever it is that you are still, as Rachel pointed out, you're still oftentimes in the workplace. You're an employee, you're a supervisor, you're a manager, you're a leader, you're an advocate. We've got a lot of people who are out there still traveling around the country, giving talks. I saw another longtime friend of Navigator, Karen Deidemeyer, is going to be honored by the COPD Foundation later this year at an awards banquet for a lot of her advocacy work. Karen is somebody who is on oxygen a lot of the time, but still organizes presentations and organizes conferences. They're going to be having a Lung Force Expo down there in Florida, where she lives. She's a very integral part of our COPD advocacy community. And that's where I'm hoping to encourage people to maintain their level of activity. You don't necessarily have to be out there flying across the country and doing all that stuff. But I want to encourage people as much as possible to not isolate themselves. You do have to deal with a certain period of grief as you're adapting to things. That's absolutely true and absolutely fair and absolutely necessary. But there does come a point where we want you to maintain your involvement with your life, because we see that, again, if you start getting into the social isolation sphere, things go down a lot faster and things become a lot more negative. Rachel again points out certain friends don't get it. They invite me to things sometimes that require a lot of stamina because they mean well, and that's absolutely true. And that's sometimes where it's a little bit difficult to walk the fine line between being active and engaged and understanding your very real limitations. Friends do mean well with a lot of this stuff, and friends and family members and everybody else don't always understand why you have these limitations. There are definitely some great resources out there. The COPD Foundation has an excellent reference guide that's designed for caregivers, and that also is used for family members. And it helps people understand that this is not simply a disease of being lazy. This is not simply a disease or a symptom of not wanting to do anything. These are very real limitations that you often have that can be overcome to a degree, but often do kind of rear their head at unexpected times. I had a patient earlier this week who has been doing rather well. She has kind of a asthmatic type or reactive airways type of disease on top of her chronic obstruction. And I had seen her about a month ago. And she said, I was doing fantastic until I went over to a friend's house. And they really like to heat their home with a wood stove. And so they fired up the wood stove, and just that 5 minutes around wood smoke, the particles and the ash and all that stuff from the wood, from the fire, has now set her off into not necessarily an exacerbation, but she's had a dry cough for about a week now, and it's been consistent, it's been limiting, and it's frustrating because it increases your self-consciousness, and if you're, especially if you're the only person, like at church or something like that, you're the only person coughing through the whole sermon or while the choir's singing or what have you. It can be very frustrating. It can be very disturbing, and that is another trigger to go down that path of social isolation. You don't want to be the person standing out in those situations. But again, it's also okay. We're in a group of people here that a lot of these people, you are certainly not alone in these feelings, and you are certainly not alone in these experiences. We have, as I said, 2,000 people who have gone through very similar things to one degree or another, whether it's coughing or whether it's carrying around oxygen, wearing a cannula all the time, or just having to stop and take some hits off of your rescue inhaler. These things happen. These things are part of life, and hopefully we'll get to a point someday where wearing a nasal cannula isn't looked at any different as wearing eyeglasses. I mean, these things are part of life, and these things are what you need to enable you to get through your day. They aren't reasons to give up. Hopefully we can convince a lot of people of that, because we don't want to see people getting depressed. We want people to be able to share their stories and interact. Whether it's in person is often the best way to go about it, but that's why groups like COPD Navigator and the COPD Foundation's 360 social website, there's a handful of other groups on Facebook and around the social media sphere. That's why these groups are so important, because a lot of times it does get to the point of being impractical to get out and about sometimes. Excuse me. A lot of the issues with transportation and things like that, often, a lot of the things that lead you to be socially isolated are often outside of your control. Even when you're doing the best that you can to manage your symptoms and all that stuff, the logistics of carrying all this stuff around are sometimes difficult. But being able to talk to people online, being able to realize that you still are part of a greater community, I think that's where some of the separation between the social isolation and the feelings of loneliness can come in. because you can be lonely and then go on to one of our groups or one of our websites or what have you, and find that you are still part of a larger community and that you don't have to be isolated. You can be talking to people who are walking the path and leaning on their shoulders and having them lean on yours in turn. And I think that can be very helpful with preventing some of those, or reducing the feelings of loneliness and preventing some of those negative complications that we see pop up with that social isolation. If you're not a computer person, first off, you're probably not watching this video, so this may fall on some deaf ears. But the COPD Foundation has a phone number that you can call to share, to do the very similar things. Or if you even just want to actually talk to somebody rather than just typing things. Again, the foundation has that available, and it's probably can't see it behind me, but it is 1-866-316-COPD, and 9 a.m. to 9 p.m. Eastern Time, Monday through Friday. It's a toll-free number. You can talk to somebody. Sometimes that's all you need to get by. So, in summary today, we are gonna wrap things up a little bit early as far as our scheduled talk. It's important to recognize a couple of things. First of all, normal in COPD is very different for everybody. Your normal would not be person B's normal, which may not be person C's normal. So there's a couple of reasons why that's important. First of all, it's important to recognize what your normal is so that when you are feeling outside that normal and you have a symptom flare-up or something like that, you can start to recognize that right away. Secondly, it's important because oftentimes we compare ourselves to other people as a measuring stick, and that's not being fair to yourself. You know, you look at somebody else who is not coughing, and if you're a person who has bronchiectasis or chronic bronchitis type of COPD, you can wonder, why am I coughing all the time? Why do I have to be the one that's coughing? Is my COPD worse than theirs, or vice versa? Thinking, well, they're worse off because they're coughing all the time and I don't have that. So maybe I shouldn't be complaining as much when I get short of breath. Each person's normal is going to be very different from another person's, and so you're doing yourself a disservice when you're trying to compare yourself to other people's cases. Compare yourself to your personal baseline and your personal normal when you're trying to figure out if you're having a bad day or not. And also make sure that you're not comparing yourself to other people so much that you're leading yourself right into isolation, right into loneliness, and right into getting busy dying, as the quote goes from Shawshank. Make sure that you're staying as involved as you can and as involved as you want to be, or a combination of the two, so that you can continue on getting busy living instead. And living not only that, but living your best life while you're at it. Because it is very possible. We have a lot of stuff that can help you manage these symptoms and manage your activity and all that stuff, so that you can be engaged and present with as many people as you want to be. So we can't fix everything. We can't fix all the cases, but we can certainly get things as well as we can. And hopefully everybody out there watching is going to be talking with their clinicians to make sure that they're on the maximum the optimized management plan. And if you feel like things could be better, then talk to your clinician about that. Talk to your provider about that. We've found that most people with COPD are actually satisfied with their treatment plan. But a lot of them don't feel that they're optimized. So when we talk about that a lot when we're doing presentations, I like to say that people are satisfied because they don't necessarily know that things could be better, because we as clinicians have not done a great job at proving things can be better. So never settle for what your provider is telling you is the best we can do, because we can always try to do better. Exercise, yes, that's actually a great point, Sam, for bringing that up. Exercise is a tremendous feature of this, and again, it may sound a little bit counterintuitive, may sound a little bit backwards. If you're getting short of breath, just getting up and walking around your living room, how can you get exercise? But just like when we tell our athletes that we need to do training to get them up into shape, just like I just got done with a run of a physical therapy for a little bit of a knee injury I had. We still have to do things to strengthen our bodies and to make sure that we're not trickling down spiraling down the well there. Exercise is a fantastic thing, and I know a lot of people who have gone to pulmonary rehabilitation programs, exercise programs like that, who get arguably just as much value out of the socialization as they do from the exercise. So it's important to find a good program in your community, whether it's a Silver Sneakers type program, whether it's a pulmonary rehabilitation program, if we can get you eligible for that, and if we can get a program in your area. But make sure you're staying active, make sure you're staying involved, and make sure you get the physical and the mental benefit from getting involved in those types of programs. So thank you for bringing that up. Kathy mentions her relative normals: no mucus or coughing unless allergies and sinusitis are rearing up, and that's again, that's very common. We see a lot of overlap between allergies and asthma and chronic disease. The biggest difference between asthma and COPD is that when we optimize your breathing with COPD, you're still below what we would expect to see from people of your type of demographics, your age, your height, your gender, that sort of thing. With asthma, we can fully reverse all that stuff. With COPD, we can only partially reverse it. But we still see a lot of overlap. And so we see a lot of people, it's pretty normal for them to have pretty good symptom days unless they have sort of an allergy attack. So it's important to recognize that can be part of the normal also. So, with that's our half hour of scripted conversation, or at least prepared remarks and all that fun stuff. This is the second half of COPD Navigator Live, is always dedicated to questions from what I affectionately call the peanut gallery sometimes. This doesn't have to be necessarily involved with the topic of the day, although it's certainly welcome if you are looking for more commentary or have any questions about anything that was mentioned during the first half of the session. That's always welcome. But this is kind of whatever is on anybody's mind out there in COPD world. As I'm waiting for people to type up their questions there, I'll give you some time to do that. I do want to point out that we are about 10 days away, I guess 11 days, 12 days, depending on how you want to count, from COPD Awareness Month. November is always designated as COPD Awareness Month. We have a lot of activities scheduled around the country to raise awareness and bring attention to COPD and try and get to shine some light on what is, of course, an under-recognized disease. One of the themes this year is going orange, as it has been in the past. Orange is the official advocacy color for COPD, awareness color, whatever you want to call it. So there will be a lot of things available on social media to Facebook filters and images and stuff like that to share infographics. I hope to have some things personally through COPD Navigator group. Again, that's our group on Facebook, facebook.com/groups/COPD Navigator. Hoping to come up with some infographic kind of things. I know the foundation will be bringing up a lot of that stuff too. We have here in Michigan, I was able to get a statewide declaration from the governor's office for COPD Awareness Month. I know there are a few other states around the country that are doing things like that. But as was pointed out on our state advocacy captain talk webinar earlier this week, it's not just about getting the proclamation, it's about using it as an awareness tool. So we're hoping to get out into the community, hoping to get some things done at the medical school here, so that we can raise some awareness in our community and have some draw some attention to that on a local level. So please feel free to share any kind of awareness activities that you're participating in, aware of, want to promote, any of that kind of stuff, all the way through the month of November. The foundation is also having a webinar on World COPD Day, which I believe is it's a Wednesday. I believe it is the 15th this year. November 15th. There will be a webinar. We'll post some more information about that in our group later on this week when I get some more information about it as far as addresses and things like that. But we will be focusing or highlighting that, and looking forward to hearing any other awareness activities that you're involved with out there in Facebook land. So. Another quiet week here on Navigator Live, huh? Not a lot of questions or commentary coming up here. So we'll give it a few more minutes, and then we'll quite shut things down for the week here. Again, next week is Respiratory Care Week. I want to highlight that also. My fellow colleagues are looking forward to that very much, my fellow respiratory care colleagues. I'm excited. This is one of the first times here in Kalamazoo we got our city commission to officially declare Respiratory Care Week throughout the city. And we've got a lot of fun activities going on again nationwide to draw some attention to respiratory care, who I know I'm a little bit biased, being one myself, but one of the, I like to call us the best kept secret in healthcare, because we do a lot for a lot of different people, but we have very relatively little awareness throughout the general public that we exist. We kind of get lumped into with our colleagues nursing and stuff like that, but I believe we have a unique and important service that we can provide to people. So looking forward to highlighting that. That's going to be the topic of our Navigator Live next week. What exactly is a respiratory therapist? Go into a little bit more detail about what we do, what we have done, what we can do, and all that kind of stuff. Hopefully convincing people to help us work to raise access to respiratory care services, including things like pulmonary rehab and pulmonary function testing. So. And then through November, another feature of us Navigator Live here, we are going to be partnering with the COPD Foundation. They're going to be sharing these videos with a little bit broader public, a little bit broader reach in celebration of COPD Awareness Month. And so we're locking down a couple of things, a couple of topics we want to make sure to hit during our 4 live sessions during November, so that we can make sure that we're covering all the bases and getting everybody the information they need to successfully manage this disease. So, dentist is a former respiratory therapist. That's interesting. That's I never knew there was a lot of overlap between respiratory care and dentistry. But over the past few years, there have been a lot more dentists being a little bit more active in the treatment of obstructive sleep apnea. Traditionally, OSA has been treated through the use of what's called CPAP, or continuous positive airway pressure. You may have, you may use, or you may have seen one of these things. It's basically a mask that fits over your mouth and blows air into your airways while you sleep, to help keep some of those airways open and cut down on snoring and cut down on apneas, or times where you stop breathing. But we've also found that a lot of times, mild cases can be helped with dental appliances. And so we've seen a lot of dentists kind of make forays into that, where we have certain appliances that help move the lower jaw forward a little bit and cut down on some of that obstruction. And so that we're pleased that we're able to pick up another professional group as far as treating that sort of thing, and another. It's always nice to have clinical allies throughout the continuum of healthcare. So. It's interesting that an RT went into dentistry, though. I haven't really seen a lot of that specifically, but it's cool. It's an interesting career track. I say that with some hesitation, as I just had a dentist appointment this week, my first cleaning after I got my braces off, and there was still a lot of the adhesive on there that were holding the brackets in place, and so that was not one of the more pleasant dental experiences I've had. But I do very much appreciate my dentist and his team of hygienists. They've done a fantastic job with me over the years, and I really appreciate the practice of dentistry. So. A little bit of a side tangent there. Not a lot of other stuff coming in, so we'll go ahead and wrap things up for today. If you are new to the program, we do this every Wednesday about noon Eastern Time, where we have a half hour dedicated to a particular topic. And then the rest of the time is open, kind of free form for questions and answers on that topic or on anything else that is bothering people out there. So I look forward to seeing everybody in a week, and really looking forward to pulling together some really cool stuff for all for Respiratory Care Week and for COPD Awareness Month coming up in November. So hopefully everybody is out there being well managed, avoiding some of the new allergens that come out during fall time. A lot of dust out there, a lot of leaves breaking down and creating all that kind of stuff. And let's not forget also, we see a lot of triggers with the cold air. A lot of times cold air can be COPD is one of those odd beasts. Again, this is depending on your relative normal. A lot of people get triggered by the hot air, and a lot of people get triggered by the cold air. So there's not an easy answer for that. It just depends on what bothers you the most, what bothers your airways the most. Maybe arguably a little bit easier to treat the cold, because you can always use a scarf or a bandana or something like that to help warm up some of that air just before it gets into your airways. It is also helpful to try to breathe through your nose as much as possible. Your nose is designed to your airways are designed to be heated by your nose and humidified by your nose before you get all that stuff down into your lungs. So sometimes when you breathe through your mouth, it doesn't quite get all that heat and humidity that your lungs are expecting, and that's what causes that trigger, that bronchospasm, all that kind of stuff. So whenever possible, make sure you're using breathing through your nose as much as possible, and then if necessary, having a scarf or something to help warm up some of that stuff before you get down into your lungs where it's going to trigger an attack. So helpful tip as we start getting into some of the colder nights especially. So we'll see everybody back here during Respiratory Care Week next week, and in preparation for many children's favorite holiday coming up here, Halloween. And try not to hit the candy too much. I know a lot of it's going on sale right now, but take care of yourselves, take care of each other, and we'll see you next week.